to go live in 2 seconds. Whoop, we're live. Pinch ourselves. Good afternoon, everybody. It is a glorious day. It is Tuesday, April 23rd, Shakespeare and Irene Renner's birthday. And we are here at Senate Democratic Caucus in Vermont, and we are here to discuss a couple of key bills that are coming up on the floor. One is not coming up on the floor yet, but is in interesting negotiation, and we need to discuss it. But neither of its cheerleaders or chief cheerleaders are here. So we'll start with I believe we're going to start with H766, and our Chair of Health and Welfare is going to introduce the, I don't actually know what the title of this bill is. Does it have a title?
Pre-authorization.
It's pre-authorization. The pre-authorization bill, H766.
Pre-authorization step
So
there.
I'm going to give it to Senator Lyons.
Okay. You have two handouts. One,
We do.
you have two handouts. One is a frequently asked question, but it does include the section by section description, so that, which is very helpful. And then you have another one, which is a handout that came from a press conference that was held to support H766, and it gives a description of what STEP therapy claims at its prior authorization and care contract standards are. So just as an overview of the bill, what the bill does is it begins to align payers, insurance companies. It begins to provide for some consistency with whenever claims that come from providers are evaluated. And it helps folks who have prescription drug needs and helps them access those drugs. Overall, the bill is about transparency, it's about alignment, and it's about access to care. Underlying all of this, the bill is also about preserving our healthcare workforce, our primary care docs in particular. So I think if you start thinking about what's in the bill and look at, I don't know where to begin with this, because the difficulty is that a lot of people think they know what these things are on the page that I have, and some people don't. But let's think.
Look, I'll give you a suggestion of where we start, which is answering Nader's question is, what's the problem we're solving? And how
I'm getting there. I just indicated to you, one of the problems we're solving is workforce. Right now, we have an administrative burden for our primary care docs and others that is overwhelming. And the administrative burden is that when they put a claim into the payers, into the insurance companies, those claims are denied. And the result is that the provider has to go back, go through patient records, fill out forms, send patient records in, and it can take anywhere up to 60 days for an initial response. What the bill does is it says you have to let us know when there might be a need for a prior authorization change within 24 hours or 48 hours at the most. The other part of this, and when you think about it, let me give you an example of what can happen when a physician says to a person, you need an MRI right away. This is an actual case where a young person needed an MRI right away. That request, that claim, was turned down by the insurance, by the payer. So what was the solution? Go to the emergency room. The result is an increase in cost to the patient going to the emergency room, possible hospitalization, and then the insurance company did not complete the claim request and looks at it, well, the insurance company would say, well, we saved money because we didn't provide that MRI. The reality is it didn't save anybody anything. It didn't save the patient and it didn't save the physician. So a prior authorization as one part of the bill offers administrative complexity for our providers, and it limits patient access when they need it. So there are many examples of this we could talk about. Step therapy, similarly, there are drugs that one might be prescribed by a physician at different levels. And so think about someone who has a depressive illness and requires a specific type of medication. So the relationship between the doctor and the patient is key in making determinations about which type of drug that individual will be given. So is this a patient who, for example, will readily take their drug? Or is this a patient who needs a drug that's more longer acting because they might forget to take their drug? So there are different considerations that are made by the physician when prescribing perhaps the depression medication. A payer might say, wait, we want you to try this other drug. So we want you to try a different drug. Well, that drug that the payer is asking for might have a very similar therapeutic effect, but it might not be as long acting. So the person who is forgetting to take their drug might not benefit from that. The requirement that you go through different steps to take different drugs when you may be very well suited to the drug that your doc is prescribing. So not going through those steps will save time. It saves administrative expense, and it allows for the patient to have access to the exact clinical treatment that the clinician and the patient have worked on together. Claims edits. This could get very complicated, as we know that there are codes for different services and treatments that doctors would prescribe or provide for their patients. So a code for laboratories, a code for x-rays, a code for MRIs, a code for blood work, a code for different types of office visits. Those codes are entered into and given to the payer for reimbursement. It's very much based on what the patient's insurance policy is. The codes that we have are established by a national organization. It's called NCCI, and those codes are pretty specific for different clinical services treatments. Those codes can be put together into what's known as a claim, and then the claim is sent off to the insurance company, and then the insurance company will look at the claims and say, no, we're going to deny this because we think there's something that shouldn't be in here. And so it goes right straight back to the physician, and they have to redo the analysis. They may even have to treat the patient differently. It takes it, for an example, a claim might be edited by the payer. So when the claims might be edited by the payer so that the patient, the doctor is sent the information back, and then the doctor has to redo the claims for that patient. Insurance companies are changing those claims edits on a very frequent basis. This bill will standardize a time frame within which those claims and the codes can be edited when they're put together. So one of the things that this bill does, beside that, is it has Medicare codes become standard for are insurers. Medicare codes are based on the national standards and CCI, and therefore, if we have Medicare and Medicaid with these standard codes, and then we ask private insurers to do the same, we increase the pool of folks who are using the same codes, and physicians have less of an administrative burden to figure out all the codes and all the claims for those 20 or so insurance companies that are working on it. So it consolidates the code claim process to make it simpler. I know I'm going fast, and I know there are a lot of questions. When I go through the floor report tomorrow, I'll be much clearer, and I apologize for not being very
This
clear.
is helpful.
So the whole point of this is whenever a claim, whenever a step therapy is made to change, whenever a code or claim is edited and made to change, whenever there is a prior authorization request, that adds significant work in the doctor's office. So what we have heard is we've heard that physicians' offices are now hiring people, hospitals are hiring people just to do claims edits, just to do prior authorization, just to look at the step therapy requirements. For every 4 physicians we have, we see a new position for folks to go through all of this administrative work. So, and there's no question, let me just step back for a minute. There's no question that there will be costs associated with this for the insurance companies, no question about it. But the significant costs that we're seeing is care not delivered. That's not calculated in with a cost for the insurance companies. Or care that is alternative. That's not added in to what the insurance companies may have to pay to restructure themselves to adhere to what are known as national codes, and to standardize their prior authorization process, to make sure that there's transparency about that process, to make sure that there's a time frame within which prior authorization is granted or at least acknowledged. So all of the things that are in the bill lead toward increased transparency about what's going on between the physician's office and the patient and the insurance company. Increased transparency, increased access for the patient, and finally, because we're reducing administrative burden, we're actually controlling costs. One of the things that we heard from the Green Mountain Care Board Primary Care Advisory Group is that administrative burden is their number one concern. The reason that we've seen primary care docs leave the state is for that number one concern. Physicians are staying up, they're staying late, they're working between 2 and 4 hours every day on all of the things that are included in this bill, in writing reports, in collecting and copying patient data to be sent to insurance companies so that insurance companies can make the clinical decisions for physicians. That's a concern. Yeah. Overall, increasing patient safety. I rattled on a little bit, but you get the gist.
This is terrific. And if there are questions, I would encourage. Yes.
Can I ask?
Because you're next in terms of presentation.
Ask everybody just to talk very briefly about something that came up in another discussion on this, which is when the first of the year rolls around, pre-authorizations from prior year expire, and then physicians' offices have to start all over again on getting authorizations for something that was previously authorized.
You're going to
So
present
that's the
next, so
compound
hold on.
fracture. You're talking about increasing the administrative burden for the physician. Exactly. Just one example. Thank you for that.
Any other questions before? Ann?
Thank you. Just a couple of questions. One, so pre-authorization, that is for procedures or tests, like things that happen. It's not for referrals to specialists, let's say.
Well, you could be referred to a specialist by your physician. But then any claim that would come from that specialist, you might even have to have that reviewed. So it depends on what the specific insurance company and policy says. There could be an edit that says before you're referred, you have to do X, Y, or Z in order for that referral to take place. So it could be something about knee surgery, and you're not going to be referred until you've had 3 x-rays and 4 injections, and you can't be referred to the orthopedic surgeon until all of that's happened. Yes, that can be part of the prior authorization.
Okay, so those other procedures could be a part of the referral.
Yeah.
Okay.
Yeah,
That's
and
helpful.
the thing is, who's making the decision for the patient? Is it the physician who has a relationship with the patient, or is it the insurance company where you're calling in and you're waiting for 8 hours, or you're waiting for 3 days? Who is at the other end of the line? Is it a nurse? Is it someone trained in the codes and claims categories that insurance company has? Who isn't? Is it a physician? So the answer is unknowable.
Okay, and my second question, if this,
Okay, we're running out of time.
I'll ask
One
my-
more question and then we're gonna move to H687.
I can ask my question offline if there's.
No, go for it.
So there was part that you mentioned, about requiring that, some process take within like 24 or 48 hours. And my worry is that by putting a deadline on it, would that not make more work for, like, it should make more work for somebody. It's not totally, is it more work for the insurance company?
So you think of it this way, think of it as the 24-hour thing is for example, for an emergency, when you've got someone who's got a severe pain in the right side and you don't know whether they should be going in for appendectomy, surgery or not, or maybe it's a head injury and you want to get them in for the MRI, the first example. You want to know within 24 hours, is this going to be allowed? Can we do this? That's all you want to know. Or do we have to send you more information to make it happen? And so we've heard from folks in that example of the person with the head injury and the MRI, we've heard testimony from a physician in this state that it took months for approval. And by the time it happened, that person had been admitted into the hospital.
Okay.
That's costly. That's costly, not just for the time, but for the future. Scary.
So it's more.
So I would suggest, just given our time frame, that additional questions, ask Ginny, ask other members of the committee, and we are on the floor with this tomorrow. But right now, we would appreciate, the caucus would appreciate from Christopher Gray, and Keisha was supposed to be with us, but I don't see her. So would you be kind enough to give us a time frame and an understanding of where we are now that H687 has been voted out of your committee, which is the Act 250 update and housing bill that has S311 in it. Would you be kind of to give us what's next?
Sure.
What are the next steps? Who's reviewing what, when, and how are we pulling it all together?
Thank you, Senator Clarkson. So the idea was to take the House bill that traveled over, the Act 250 bill, use that as a vehicle and do a single report on the bill. That will originate, the report originated out of Senate Natural, and it came out last week. And in that bill, we took S311, the Senate Economic Development Housing Bill, and we took the House's Act 250 bill, and basically we merged those two together with edits. And it's 180 pages, so I'll state a high level. And I would say overall, we have adjusted Act 250 provisions to provide for exactly the thing we've talked about since we came in, which is to facilitate the development of housing in already designated areas and where we have a capacity at the municipal level to do the kind of planning and development and review work that smaller towns, at least some smaller towns, rely on the Act 250 process to perform on their behalf. So for towns that have designated areas, and you might remember they are things like village centers, designated downtowns, growth centers, new town centers, neighborhood development areas. We've taken that as the basis for where we know we already have a lot of planning work to have established those. That becomes the focal point of enhanced development, meaning that you could be developing up to 75 units of housing with no Act 50 application at all. If you're developing priority housing projects, you can go beyond that cap as well. So it is, I will spend some time looking at maps this weekend. If you look at the designated areas and start drawing half-mile circles around them, in the case of like a designated downtown or a village center, quarter-mile radius. In the case of Bristol, I'll just stick with my hometown. It goes from being a small, a couple of blocks downtown to being the entire village. So it's a very significant expansion. I'd say at least 4 times the footprint of last year's bill to facilitate housing, and then it's all the way to the level of 75 units. So there's a very large opportunity for towns that are interested to take on, and support and facilitate and move faster on more housing. So I know how I'm sticking to the housing piece because I think that was.
No, you're doing high level. How's it moving now? Where is it now? I think it's in finance, going to approach, but there's still questions to answer. So I think those are the things people are just curious how it's flowing.
When we were, in order to keep our work timely, there were a certain number of things, for instance, accessory on-farm businesses that started to get gnarly enough legally, definitionally, et cetera, that we said, okay, we're taking that off. We're taking that out of the bill, putting it on a punch list. We'll come back to it as time allows. So because of floor today, we didn't have a chance to get that back to that item for instance. But we have a list that you all have in the committee list, whatever we want to call it, things that as time allows and we can clarify, we will look to bring back into the bill, modify, et cetera. I'm thinking Senate Economic Development may have similar clarifications. The work path is finance, approach, floor, our report, and then an amendment to be offered by the 2 committees to say, given that we now had about an extra week to churn and dig into some of these things that weren't able to be accommodated last week, maybe we figured some more things out and agreed to them, and we can put them in as well. And then we've also received a few technical corrections. Someone reads through and they go, this cross-reference is no longer right.
So technical corrections and sort of, as you referred to it, that punch list of sort of questions you didn't have time to answer are going to be mostly, if they continue, there'll be an amendments on the board.
Right. So a single bill with a single report, a single amendment to bring further work that the 2 committees have vetted to the floor to supplement that under the single report. So otherwise, we get into too many moving pieces. And I think it'll be hard for people to manage procedurally. That's the plan.
Thank you. Any questions on how that all is functioning? Because it's head spinning. Okay, great. That's very helpful. Mr. Pro Tem, do you have anything you'd like to add before we adjourn?
No, I don't.
Nothing from the exciting world of Vermont Public?
Yeah.
Thank you. Great. Oh,
We should, Alon
Nader just left.
no, I was gonna say Senator Starr has a huge.
Oh, no, we have a big announcement.
Yeah, so I didn't
yesterday.
know.
Senator Starr has decided to retire. And we are so grateful. Well, more to follow. More to follow on that. Huge. Yes, over a century, because Vermont Public this morning announced over a century of experience with the retirements of Senators McCormick, Mazza, and Starr. Well, huge institutional memory. incredible. Anyway, thank you all. We are going to adjourn for today, and I think there is trifle in Senate appropriations. Thank